Good afternoon, doctors. Good afternoon. Good afternoon. Good afternoon. Good afternoon. Yes. Good evening to all of you, beta. Good evening to all of you, doctors. Good evening. Hello. Hello. Hi, Sujit. Nida. Deepinder. Hello, beta. Good evening to all of you. Bhavin. Deepak. FMGE topper. Great name, beta. Yes, that's the attitude. That's the attitude. It should be FMG topper. Thank you. Good evening, beta. Pralad. Yes, beta. Hope all of you are joining. Yeah, so today's YouTube live session, we are actually going to tackle the clinical based MCQs that can be asked or may be asked from biochemistry. All of you might be wondering that why the name is clinical based, because biochemistry, as you all know it, is basically comes under non-clinical or the preclinical subjects beta. But please try and understand, because over the last few years, the pattern of the MCQs that has been coming in your exam FMG has changed drastically. I must add it, drastically it has changed. And even though we are having anat, physio and biochem considered as the preclinical and the non-clinical subject, but the questions that are asked in your exam beta, they are more or less clinically oriented. So in today's session in YouTube live, we are going to discuss about how clinical types of MCQs can be asked from even biochemistry, right? So in this regard, I will be taking you through the journey of 25 most important questions that are clinical based from biochemistry, and along with this we will be also discussing many important concepts behind these particular questions that might be helpful or will be helpful for you to solve any other questions that are asked from the topics that are aligned with these questions beta. So without wasting much time, let us straight away start with this discussion. Now please try to understand here beta. Yeah, good evening beta. Good evening Afzal, Prahlad. Good evening. Good evening beta. Yeah, what I was saying that in today's session we will be mainly focusing on the clinical based question beta. But please try and understand, if I ask you to remember the weightage of the MCQs that are asked from biochemistry, please remember there are basically three chapters. Please try to remember beta, there are basically three chapters from where bulk of the MCQs are actually asked in your exam beta. Three chapters are extremely important. Please remember the enzymes chapter. Enzymes chapter, basically they ask you direct questions. So basically we are not going to tackle the enzymes chapter related questions in today's session. Second and third most important topics are actually beta carbohydrates and proteins. Please remember, carbohydrate metabolism and protein metabolism, these are the two hottest cakes that are there in the subject of biochemistry beta. If you recall all the MCQ that has been asked in last 3 or 4 odd years, particularly in last 6 or 7 attempts in FMG, please remember most of the MCQs has been asked from the carbohydrate metabolism and the protein metabolism. If I talk about the weightage, if you read these three chapters nicely, this enzymes chapter, carbohydrates and proteins means I'm talking about the chemistry part, and the metabolism part, carbohydrate primarily the metabolism, this itself will give you around 14 to 15 MCQs that will be coming in your exam beta. Talking about the last FMG exam, the number of MCQs that were asked from biochemistry were also on the little bit on the higher side. There were around 23 core biochemistry MCQs with some overlapping subjects. The number had gone up to 25. So 25 odd questions were there from biochemistry. In upcoming session, in upcoming FMG exam of June 4th also, we are experiencing or we are expecting, let us say, almost close to that. And these are the three chapters that you need to focus while you are revising, right? So today's session, let us straight away first talk about the first MCQ that are clinical based can be asked from biochemistry. One more thing I must tell you beta, without straight away looking at the question, please remember, although there might be some 3, 4 or 5 liner questions that are aligned with biochemistry, but these MCQs level are actually quite easier as compared to the core clinical subjects beta. You already had a session with Vineet sir day before yesterday. Please try to understand there the MCQs were mainly more towards the core clinical concept. But here in biochemistry, basically if you read the question nicely, you will be able to understand that they are actually asking you from the topics which are aligned with the clinical concepts, right beta? So here let us try to see the first question that can be asked or may be framed from biochemistry, that is of clinical type. Mr. X, 40-year-old male, presents to OPD with generalized weakness. Please try to follow here beta. Whenever we talk about any long liner questions, our job is to basically focus on the positive findings. Even during the classes, even during the sessions, I always tell you to focus on the positive findings beta. In a long liner, your job is to always find the positive findings. So let us focus in this regard. 40-year male, OPD, generalized weakness, recent complaints of loss of appetite. That means this person is actually experiencing some anorexia, right? Also adds noticing swelling around his bilateral ankles whenever he walks a mile. So please try to understand this swelling. Simply we can talk it as pedal edema beta. As we can see here, bilateral ankles swelling, pedal edema can be there. Further he adds that he has been an alcoholic since last 15 years beta. There is positive history for chronic alcoholism. 15 years of chronic alcoholism. Let us go further. Basically they have asked it to be a vitamin deficiency, and all of you know beta, all of you know that the most common cause of vitamin B1 deficiency in India is chronic alcoholism. Chronic alcoholism, right? So this is what is the case beta, what is the diagnosis? Without looking at the option, what is the diagnosis that you guys can think of? What is the diagnosis here beta? Yes, what is the diagnosis here beta? What is the diagnosis here? Diagnosis here is very, as we can see here beta, this is very case. Please try to understand generalized weakness, loss of appetite, anorexia, as well as pedal edema whenever walking a mile, and chronic alcoholism is there as a positive history. And the question is, which of the following is most likely to be important in assessing the vitamin deficiency in this patient? All of you know we have something known as erythrocyte transcatolase activity that can be estimated or can be assessed to diagnose a case of B1 deficiency. Yes beta, yes beta, exactly correct, correct. Answer is A. Yes, Jayashree, correct. Sunil, Imran, Alina, yes beta. Vitamin B1 test. Thiagarajan, yes. Great beta, great. Let's clap for all of you beta. Yes, correct. The answer is actually A beta, and yes, the diagnosis here also is very great beta. Gary, very yes. Imran, Navi, yes. Very Thamin, Jivita, yes. Great beta, great. So this is a case of very, and all of us know the diagnosis can be done by RBC transcatolase activity, right? This is the correct answer beta. RBC transcatolase I have just now highlighted in the pink color beta. All of you can remember this. So in this way, from biochemistry as well, the question can also be asked. Now let us try to focus on the some other options that has been given here. Please remember, please try to focus on the option number C here beta. Please to focus on the option number C here beta. Please remember, can somebody come up with the answer that when RBC glutathione reductase activity should be measured in what sort of vitamin deficiency? If somebody can come up with the answer beta, if somebody can come up with the answer, option number C will become the answer. When, in which vitamin deficiency we have measurement or assessment done by option number C, glutathione reductase in our erythrocytes. Can somebody come up with the answer beta? RBC transcatolase, all of you know it is B1. Very. What about this? Yes, great beta, great. Sujit, yes, Sujit, vitamin B2 riboflavin. Sri Sharan, great beta. So please remember, this is actually done for vitamin B2 deficiency. Please mark it beta. This is vitamin B2 or riboflavin deficiency. So first one is for B1 deficiency, and vitamin B2 is actually assessed by RBC glutathione reductase activity beta. Please remember, in this regard, just try to add a few more points beta at what I am writing. Transaminase, please remember beta, in RBCs also we have transaminase activity. RBC transaminase is actually done for B6 deficiency. Important point to be noted beta, B6 or pyridoxal phosphate. Important point to be noted. Please know this beta, B1, B2, B6. If I talk about B9 deficiency, that is folic acid deficiency, please remember this is done by FIGLU excretion test. These are few important points to be remembered from this topic beta. How vitamin deficiencies can be assessed. Please remember FIGLU excretion test. FIGLU excretion test. Please remember this beta. B6, B9, as well as please remember B12 deficiency can be assessed by methyl malonyl CoA level. Methyl malonyl CoA level. Please remember either in blood or even in urine if it is passed. So please remember these 5 important vitamin deficiencies beta. Let us quickly revise this important point. B1 deficiency by RBC transcatolase, B2 deficiency by RBC glutathione reductase, B6 deficiency by RBC transaminase, B9, please remember FIGLU excretion test. We have a lot of other tests, but at undergraduate level in FMGE, they will only ask you, if at all they ask, regarding FIGLU excretion test or histidine loading test. And B12 deficiency can be assessed by methyl malonyl CoA level either in blood or as well as in urine. Right. So please remember these important points from the vitamin deficiencies and how it can be assessed. Right, beta? So in this question, the answer was this RBC or erythrocyte transcatolase activity diagnostic test for assessment of thiamine deficiency. You don't have to remember this value beta. Basically, the whole bat transcatolase is somewhat around 9 to 12 micromoles per hour per ml. Whereas in case of RBCs, please remember this is very low, 0.75 to 1.30 units per gram of hemoglobin, right? Because we are estimating it within the RBC. So per gram of hemoglobin, how much units of transcatolase activity is patient? You don't have to remember these values, not required. Just remember the name RBC transcatolase. Moving to the second important question beta that can be asked from the clinical type questions. Yeah, again, Mr. X, 52-year-old male suffering from chronic liver disease. Chronic liver disease. Please try to understand beta. Here itself they are telling you that the patient is suffering from chronic liver disease, CLD. CLD. Please remember 3 C's are very common in Indian setup. One we have is CLD, second we have is CKD, chronic kidney disease, and the third one we have is CVA, cerebrovascular accidents or stroke. These 3 C you will be frequently encountering when you are doing internship in India, right? So chronic liver disease suddenly presents with slurred speech. Let us try to find the positive findings beta. Slurring of speech, blurred vision, blurring of vision, and one episode of convulsion. Worried son adds that his father has been non-alcoholic and a non-smoker, no history of smoking or alcoholic. Workup revealed that the liver enzymes like ALT is quite high. All of you know ALT normal level is somewhere between 0 to quite high. AST also it is raised, and ALP actually is close to normal. However, the plasma ammonia level is found to be quite high. Normal value has already been given. Maximum upper limit is 32 micromoles per liter. Here it is 96 micromole. The high ammonia formed in brain is usually detoxified by, that is the crux of the story beta. Always please remember, in long liner question it is always better to read the last line first. So please try to understand here beta. Basically they have given you some junk of the story, and please remember they have simply asked you a question that may be asked in the form of one liner as well. High ammonia formed in brain is usually detoxified by. Yes beta, all of you have marked the answers correctly. Great beta, great. All of you have marked the answer correctly. Clap for you beta. All of you have done it correct. Please remember beta, the answer is C, that is glutamine. Please remember beta, the correct answer here is C, glutamine. Please remember, is the form in which the toxic ammonia can be transported as glutamine from brain to the liver, and in the liver finally it will undergo urea cycle so that the toxic ammonia can be converted to non-toxic urea. Right beta, important point to be noted. Hope all of you can remember this. And please remember the last option here that has been given here, alanine. Please remember this is actually the non-toxic form from muscle. Non-toxic form from muscle. Please mark this one also beta. This can also be asked as a question. Important point to be noted here beta. From brain, the non-toxic form in which the ammonia can be transported, it is glutamine. And from the muscle, particularly the skeletal muscle, beta, particularly from the skeletal muscle, it is transported as alanine. Important point to be noted. Hope all of you got this correct. No confusion here, beta. Basically, there was a case of hyperammonemia, and all these are the findings of hyperammonemia, beta. Please try to focus here. Slurring of speech, slurred speech, blurred vision. There can be also tremor, and there can be also episodes of convulsion. All these chronic liver disease, liver is injured, urea cycle is not able to work properly. So please try to understand, urea formation, that is ammonia detoxification in the liver, is jeopardized, and there will be a case of hyperammonemia. So ammonia is not converted to urea. So please remember, beta, important point to be noted, how this question can be asked in this format as well, right? Just a quick recap of this ammonia transport. All of you will be able to recall this, beta. Ammonia transport, how it happens. Please try to focus from most of the tissues, as well as if I talk about in brain, most of the tissues as well as in brain. Please remember the non-toxic form in which the ammonia or the ammonium ion is trapped is glutamine. Then glutamine comes via blood to the site of detoxification, that is our liver, and in the liver it is actually getting detoxified to form urea. Right, beta? Right, beta? And from the muscle, just try to understand, from the muscle, the ammonia can be trapped as ultimately alanine, and alanine will be coming to the liver again, and in the liver it will be again converted to urea finally, and the byproduct will be pyruvate, and pyruvate will be again converted to glucose by the process of gluconeogenesis. All of you know, beta, in the liver we have a process of conversion of non-carbohydrate sources to form glucose. Pyruvate is a non-carbohydrate just like lactate. So pyruvate can be converted to glucose, and this new glucose, please try to understand here, beta, it can again come back to the muscle where it can be reutilized to form via glycolysis. So in the muscle there can be glycolysis, and again pyruvate can be regenerated, right? So in the liver we have gluconeogenesis. So please remember these two pathways are linked here. Alanine was actually focused on bringing ammonia from the muscle to the liver, but during this journey he is able to produce a byproduct known as pyruvate. That pyruvate can go back to form new glucose, and this new glucose can be channelized to the muscle for again reutilization. So please remember, this particular process is a type of gluconeogenesis as well as mobilization of the ammonia from the muscle to the liver, and this particular cycle is also known as glucose alanine cycle, which is also known as, beta, Cahill cycle. Please remember this, beta. Cahill cycle can also be asked as an important question in your exam, beta. Cahill cycle is the conversion of ammonia to alanine, alanine to pyruvate, pyruvate to glucose, glucose again coming back to form pyruvate. So alanine and glucose interconversion ultimately is known as Cahill cycle, and this is also a type of gluconeogenesis. All of you definitely would have heard about Cori's cycle, beta. आपने सुना होगा, आपने जरूर सुना होगा बेटा, इसको ध्यान दो, आपने जरूर सुना होगा कोरिस साइकिल. You would have definitely heard कोरिस cycle. Here in place of alanine there will be just lactate. Entire story will be remaining same almost. Lactate will come to liver for new glucose production, that is Cori's cycle. Alanine now is coming to the liver for new glucose production by gluconeogenesis, that is Cahill cycle. Both are C, one is alanine, second one is lactate, right? Both of them, they are, beta, important for gluconeogenesis, and this Cahill cycle most important function is detoxification of ammonia, and it is channelizing ammonia in the non-toxic form alanine to the liver. Ammonia transport, right? Let us move to the next important question, beta. Yes, please remember here they have basically asked read the last line first. Here, beta, again appears to be a long line type of question. Let us read the last line first. Which is the most specific test to be performed in this patient in diagnosing the conditions? That means in this question we need to read the question carefully, look for positive findings, because first we have to diagnose this case, right, beta? Just try to have a look. Mr. X, 40-year-old, returned from his best friend's wedding. Please read the question carefully, beta. Best friend's wedding, late night, goes to sleep, with no problem. Next morning when he woke up, experienced an excruciating pain in lower limb. Excruciating pain in lower limb. And it was so severe that he was unable to even stand. And he was rushed to the OPD and shared that this was the first episode and the pain now is more localized around his right great toe. Around his right great toe. Important point to be noted, beta. Around his right great toe. History taking revealed that he had consumed a full bottle of vodka last night. Best friend's wedding. So much happy. He had consumed basically binge alcohol drinking, vodka, one bottle full. What is the diagnosis, beta? What is the diagnosis? What is the diagnosis, beta? First try to find out what is the diagnosis in this case. Yes, somebody can come up with the answer, beta. What is the diagnosis? Yes, beta, gout. Yes, Sunil. Yes, Sunil, great, beta. Doctor, yes, it is gout. It is a case of gout. So first try to understand, beta, how a patient of gout actually classically presents. Please try to understand, beta. Alcohol intake always precipitates acute attack of gout. Please try to remember this important point, beta ji. Very, very important point. Acute attack of gout can be precipitated by alcohol, because alcohol basically decreases the pH, and at lower pH basically these uric acid are crystallized and they form monosodium urate crystals, beta. MSU crystals, all of you know, monosodium urate crystals are formed. These are monosodium urate crystals are actually formed in case of a patient of gout. Usually acute attack of gout is always preceded by an history of binge alcohol drinking, one full bottle of vodka. Please remember, they will usually go to sleep asymptomatic, no symptoms, but whenever next morning they actually wake up, there will be an excruciating pain and they can even fall. They will not be able to stand. The pain will be so severe at the great toe, and this deposition of these monosodium urate crystals around the great toe synovial cavity, this is actually known as podagra. Please remember, beta ji, this is known as podagra. Maybe they can ask you simply on this term. Podagra means deposition of the monosodium urate crystals around the great toe synovial cavity, beta. Very, very important point. Please remember, beta. Important straight one-liner question as well. Most common joint involved in gout. It is not your knee joint, not your ankle joint, beta. This is the first metatarsophalangeal joint. That is our great toe. That is the most common site. Second most common is ankle. Third most common is knee. Please don't make a mistake in this one, beta. Gout attack, usually acute attack, there is most common joint involved is our first metatarsophalangeal joint, great toe, and wherever this is deposited, monosodium urate crystals deposition, these are called as podagra, beta, podagra, right? And we all know, during the acute attack of gout, if you do plasma uric acid, beta, if you do plasma uric acid, please remember this is either normal or even decreased. Very, very important point to be noted, beta. Please remember, during the acute attack of gout, the plasma uric acid is usually not elevated. Only in chronic cases of gout, uric acid levels are elevated. So during the acute attack, the best possible way to diagnose this condition of gout is to go for arthrocentesis. What is arthrocentesis, beta? Take a needle, put it in the synovial cavity, aspirate the synovial fluid, send it to the lab and look under the microscope and try to look for monosodium urate crystals, beta. Important point to be noted. So in this case, what is the best way? Yes, all of you have done this correctly, beta. Yes, beta, great answers all of you have done. Metatarsophalangeal joint, great, beta. First MTP, great, all of you have marked it correctly, beta. The answer is synovial fluid uric acid, beta, marked in pink color. This is the correct answer to this question, beta. Synovial fluid uric acid should be elevated or should be measured in a case of acute attack, beta, acute attack. Please remember, if they give you a history of chronic case of gout, in chronic cases we actually do not go for arthrocentesis, then we actually have to go for this plasma uric acid, beta. So plasma uric acid is actually for chronic cases, whereas acute attack of gout, best way to diagnose is always to go for arthrosynthesis and look for monosodium urate crystals beta. Please remember, under polarized light they show negative birefringence, needle shaped negatively birefringent crystals under polarized light. This is how they basically look like beta. Please try to look at this beta. This is actually the classical picture. They can also give you this image based question. They can also give you this image based question beta, that this is monosodium urate crystals. Please remember, don't get confused here beta. Please do not get confused beta. Isko dhyan do beta. Isko dhyan do. This blue that you are seeing as well as this yellow that you are seeing, all these are actually monosodium urate crystals. Just try to see here beta. Whenever you are looking at blue are actually perpendicular in this diagram or in this image, and yellow, if you see, they are particularly horizontally oriented. Both of them, they are actually monosodium urate crystals, but whenever you are looking at them, that's why we say that polarized light, they show negative birefringence to the polarizer. Whenever we are looking at them perpendicularly 90 degree or close to 90 degree, they are blue. Whenever they are horizontal or close to 180 degree, they are basically yellow. Both of them are actually monosodium urate crystals. So please remember this beta. These are MSU crystals that can be seen in our synovial fluid. Important point to be noted beta. These are needle shaped. Please remember the shape beta. These are needle shaped birefringents. Birefringent, needle shaped and birefringent. Why bi beta? Why two? Because just now we have seen they can be either blue or they can be yellow depending on their orientation towards the polarized light, right beta? Needle shaped birefringent monosodium urate crystals. These are classically seen in case of gout. Yes, yes, in chronic serum uric acid. Great beta, great. Abhideo, great beta, great beta, great. Please remember beta. Moving to the next question beta, question number 4, image based questions that can be also asked. Please remember, what is the most likely mineral deficiency that can lead to the following condition? Answer beta, answer to this question beta. Answer to this question. Which mineral deficiency might have led to this beta? Please look for rashes around the mouth, around the oral cavity, as well as rashes around the genitalia beta. Yes, yes, great beta, great Bhavin, Shivam, Sachidanand, Arman, Jivita. Yes, great beta. The diagnosis straightforward is zinc deficiency. Please remember beta, this is a classical finding that we get in zinc deficiency beta. And all these type of dermatitic rashes that we are getting here, please remember, these are classically called as acrodermatitis enteropathica beta. Please remember this dermatitic pattern, we call it as acrodermatitis. Yes, great beta, great Bhavin Tambolia, great beta, great. Acrodermatitis enteropathica. Please remember this beta, important point. It can be asked beta. Acrodermatitis enteropathica, important point. Let us quickly have a look at the indications of zinc deficiency. Please try to focus on the most important one beta. Please try to look for the most important one beta. Please remember, there can be an ongoing diarrhea. I'm just highlighting those important points that was already asked in your exam. Please remember, there can be poor wound healing. Whenever we see a question of wound healing delay, we always try to think about vitamin C beta. Yes, that is there. Vitamin C deficiencies will also lead to poor wound healing or delayed wound healing. But please remember, from the minerals, even zinc is associated with poor wound healing beta. Please try to understand, there can be also brittle nails. There can be brittle nails beta. Important point to be noted, brittle nails. Please remember. And please remember, poor memory and concentration. Please remember, these are important points that was already asked in your exam beta. Please try to remember this beta. Indications of zinc deficiency, right? Acrodermatitis enteropathica. Coming back to the question beta, please remember, iron related questions all of you already know. Calcium also you know. Please try to focus on this chromium beta. Sometime from chromium also can be, MCQs can also be asked beta. Please remember, if there is a chromium deficiency, it will lead to something known as impaired glucose tolerance. Please remember this beta. This was also asked in your exam. impaired glucose tolerance is noted in which mineral deficiency? मार्क इट, इसको मार्क करो बेटा, ध्यान दो, ध्यान दो बेटा, ध्यान दो, ध्यान दो, इंपॉर्टेंट पॉइंट बेटा, important point. Impaired glucose tolerance is classically noted in chromium deficiency. Please remember, why in chromium deficiency, what is the function of chromium, why glucose tolerance, how it is related. Please try to remember beta, somebody can come up with the answer. What is the relationship between chromium and insulin? Chromium and insulin, chromium and insulin beta, chromium and insulin, please remember, it potentiates, please write it down beta, it potentiates the action of insulin beta. Please remember beta, yes, potentiate, grace beta, Dr. OP Chaudhary, great answer beta, potentiates. This is the word that I need you to understand here beta, potentiates the action of insulin. Please mark it beta, important question that was also asked in your exam. Potentiates the action of insulin, yes beta, important point beta, important point, right? Zinc, iron, calcium, iron related questions, all of you know that. Also there is relationship with vitamin C and all. Vitamin C, what is the role of vitamin C in iron beta? What is the role of vitamin C in iron? Vitamin C, we all know it is a reducing agent, right beta, it is a reducing. So basically it helps the iron to stay in the ferrous form. Whenever we eat iron in the food, it is present in ferric form, but ferric form doesn't get absorbed from our GI tract. During the absorption, iron must be present in the ferrous form. Who will do this conversion? Please remember, this is primarily done towards the lumen side, done by vitamin C. So vitamin C helps in the absorption. Yes beta, absorption of the, yes, great beta. Sushma, Zain Khan, yes, correct answer beta. Basically helps in the absorption of iron from the GI tract, right beta, right? Let us move to the next question. Important point. Yes, question number 5. Which of the following enzyme is likely to be deficient in this child? Basically they are asking about enzyme deficiency. So basically we have to focus on the diagnosis part of this one. Please try to understand this beta. Yes, OP Chaudhary, again correct. Ferric to ferrous beta, ferric to ferrous conversion, yes. Now move to the next question. Thank you beta, thank you. Yeah, 10-year-old child, aggressive behavior, poor concentration, joint pain, lower limb, reduced urine output. Mother, however, gives history of self mutilative behavior beta, stating that he tends to mutilate his own fingers. Yes beta ji, all of you have corrected, all of you have marked it correct beta. Clap for you all beta, all of you have marked this correct. Yes, this is a clear cut case of Lish Nihan syndrome, classical hallmark finding beta ji, self mutilation. You have to tie these children's hand and legs so that they don't self mutilate themselves. If you keep their hands and legs open, they will try to even bite off their fingers, they will try to chew off their lips. Please try to understand beta. Very extremely hostile male child is classically seen in Lish Nihan syndrome. Please try to remember beta. One funny thing here, it is only affecting male child, male, only male. No females can be affected by Lish Nihan syndrome. Only male child, 10-year-old male child. Actually, ideally in the MCQ, they should have given you only male child. Only affects extremely hostile male child, Lish Nihan syndrome, and this is classically noted due to complete deficiency, absence of the first enzyme here, that is HGPRTase. What is the full name here beta? Hypoxanthine guanine phosphoribosyl transferase. Please remember this beta. Hypoxanthine guanine phosphoribosyl transferase, full name is this, short name HGPRTase. Please try to understand this beta. Lish Nihan syndrome. During our classes at MIST, we had discussed about this particular point beta. We had also discussed that Lish Nihan syndrome is another such disorder of purine metabolism, just like gout. So here in this case also there will be cases of hyperuricemia, and this hyperuricemia here beta, it is seen here as joint pain. Please remember beta, this joint pain that you are seeing here, this is due to the again gout like features that can be also seen in case of Lesch-Nyhan syndrome, complete deficiency of this. There can be also kidney stones, nephrolithiasis can be there, and due to nephrolithiasis or kidney stones beta, here we have decreased urine output. Please try to understand, even if they don't give this self mutility behavior, let us say they make the question tougher and they don't give the hallmark finding, still you have to arrive at your diagnosis. Please remember, apart from hyperuricemia, there can be also kidney stones at an early age. 10-year is not the age of usually to get an kidney stone, right beta? But in this Lesch-Nyhan syndrome, please remember there can be kidney stones. And also try to understand beta, we have a classical finding also seen in this case. Yes, orange sands in diaper, somebody answered this beta, orange sands in diaper. Yes, I saw this. Yes, so please remember this beta. Yes, correct. All of you have marked it correctly beta. Lesch-Nyhan syndrome, great. Please mark it beta. Apart from these, we also have an important thing. Yeah, we have an also important thing here beta, mark it here beta. Sorry, yeah, just remember important features that we have here. Self mutilation, please remember, just try to look at here. Nails are absent beta, look closely here beta, look closely. Nails are actually absent in this image. Obstructive uropathy, please remember beta, obstructive uropathy, please can be due to kidney stone, nephrolithiasis. Nails are absent. And also try to see here beta, here the entire lower lip is gone. Please try to see here beta, entire lower lip is actually missing. So this is an hostile behavior. And please remember some other important point that we need to remember from this topic. First important point, please remember, there will be hyperuricemia, there will be hyperuricemia, and these patients, they can actually present with gout. There can be nephrolithiasis, there can be nephrolithiasis or kidney stones. Basically, as rightly said by Dr. Arman over here, please remember, great, that it is basically causing obstructive uropathy. Let us write obstructive uropathy beta. Yes, correctly answered, obstructive uropathy. Please remember, this is basically X-linked beta ji. This is classically X-linked. If you talk about their inheritance patterns, this is X-linked. Particularly, this is in a recessive trait, X-linked recessive. Please try to understand this beta. Also try to understand, here we have something known as orange sands in diaper. Orange sands in diaper. The baby's diaper will be having orange sands. Please try to understand this beta. Orange sands in diaper, important point to be noted beta. Orange sands in diaper beta, orange sands in diaper, important. There will be also some other features, there can be dystonia and all those. I'm not going into the mainly all those things not required for FMGE exam. And just I told you last one, do not forget this beta, extremely hostile male child, extremely hostile male child. This affects only male child and they are extremely hostile. Self mutilation, all of you can easily remember, right beta ji? Important point to be noted here. Yeah, so Shahana Parveen, you want to see the question number 1 and 2? Yeah, I think you joined late beta. Question number 1 and 2 we had already discussed beta. Question number 1 basically was a case of vitamin B1 deficiency where assessment was done by RBC transcatolase. And beta, question number 2, basically we were talking about how do you detoxify ammonia from the brain so that it can be channelized to the liver in its non-toxic form. This is by glutamine, right beta? Let us go ahead. X-linked recessive, it is already done. Let us move to the next important question beta after Lesch-Nyhan syndrome. Yes, somebody also answered about Keeley-Sigmiller syndrome beta. Great, very nice to hear that. Abhimanyu, you have asked about Keeley-Sigmiller syndrome beta. Please try to focus here. This HGPRTase enzyme If it is complete deficiency beta, then we have Leishman syndrome. But if we have only partial deficiency of this, that means if around 20 to 30% of enzymatic activity is present of this hypoxanthine guanine phosphoribosyl transferase, 70% lost, 30% still remaining intact, we have something known as Kelly-Sigmiller syndrome. Writing it short beta, Kelly-Sigmiller syndrome. Yes, you had answered. Abhimanyu in the chat section has replied, what is Kelly-Sigmiller syndrome beta? Kelly-Sigmiller syndrome is the partial or incomplete deficiency of this same enzyme. In that case, we do not have the self-mutilative behavior there. There we have another clinical finding that is known as chorioathetosis beta. We will be seeing hyperuricemia over there to some extent, but mainly the differentiating feature between Leishman and Kelly-Sigmiller syndrome is chorioathetosis. Leishman syndrome, self-mutilation. Chorioathetosis, we have this Kelly-Sigmiller syndrome. Right, beta? Let us move forward. Question number 6 that we have here. 12-year, we can read this question beta, not very long. So let us quickly read this question. 12-year-old child was brought to the OPD, excessive curly hair. First positive finding. Workup revealed it to be due to defective collagen cross linking and primary due to dietary deficiency of copper. Beta, diagnosis, 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 diagnosis beta, diagnosis, diagnosis. Beta, read the question carefully. Beta ji, please, please, please read the question carefully. Don't jump into the option. प्लीज डू नॉट लुक एट द ऑप्शन राइट नाउ. फर्स्ट ट्राई टू थिंक अबाउट द डायग्नोसिस. बेटा ये क्या लग रहा है सुनने में? एक्सेसिव करली हेयर बोल रहा है, एक्सेसिव करली हेयर बोल रहा है बेटा, एक्सेसिव करली हेयर बोल रहा है बेटा, excessive curly hair. No beta, this is not a case of Wilson disease, not a case of Wilson disease beta. Please try to see carefully beta, read the question carefully beta, don't jump into conclusion. This is not a case of Wilson disease. Wilson disease में कहाँ curly hair होता है? Wilson disease something is hepatolenticular degeneration. You have those eye changes, you have cataract, sunflower cataract, chalcosis, you have all those other important features, cave ring. Not Wilson disease beta. Please remember here they have told you curly hair and defective collagen cross linking. Defective collagen cross linking, we all know beta, it is done by lysyl oxidase enzyme, and lysyl oxidase enzyme we all know is dependent on copper as a cofactor, right beta, copper as a cofactor. So if this is deficient, copper is deficient, then lysyl oxidase won't be able to work, collagen cross linking will be defective, weak collagen will be formed, and please remember we will be having excessive curly hair. What is the diagnosis? Yes beta, now the answers are coming. Yes, yes, now the answers are coming beta. Mohammad, Zain, Suresh, Deepinder. Yes, please remember beta, the diagnosis here is Menkes kinky hair syndrome, Menkes kinky hair syndrome or disease or syndrome, right beta? And all of you know this is due to the gene mutation of ATP7A, ATP7A gene mutation beta ji, ATP7A gene mutation. Please remember, read the question carefully beta. My sincere request to all of you to please read the question carefully before straight away jumping into options. ATP7 है इसका आंसर. What about ATP7B? Many of you were answering about ATP7B. Let us quickly see this beta. What is ATP7B? ATP7B gene mutation leads to Wilson disease. This was also recently asked in your exam. Wilson's disease, right? Wilson disease is what beta? This is ceruloplasmin deficiency and copper excess. Please remember this beta. CP deficiency, ceruloplasmin deficiency, and copper excess. Ceruloplasmin beta is actually an enzyme. It has got two enzymatic activity. One is peroxidase. It converts ferrous to ferric in the blood so that transferrin can carry it. And copper excess, please remember, basically goes for deposition in the liver, where initially it causes hepatocellular degeneration. From there, if it goes into the brain, we have basal ganglia, lenticular degeneration. Even in our lens, if copper gets deposited in lens, copper is treated as a foreign body, not a normal thing to be found in lens. and this intraocular foreign body containing copper, these are considered as chalcosis, which can ultimately lead to cave ring, as well as it can go and form the cataract, sunflower cataract. Please remember, sunflower cataract is also seen in case of Wilson's disease, that is due to ATP7B gene mutation beta. Yes, then panda sign on MRI. Yes, beta. So please try to understand. I'm not going into the detail of all those, beta. Please remember Wilson's disease, hepatolenticular degeneration, beta. Hepatolenticular. Yes, ceruloplasmin, beta. Please remember it has got two functions, beta. First important enzymatic function is peroxidase. Peroxidase. Yes, Dr. Arman, you are also interested in knowing the second one. Please remember, second important enzymatic function is copper binding ATPase. Please remember, the second function is copper binding ATPase. Ceruloplasmin has two enzymatic activity, primarily beta peroxidase, ferroxy, that means it can convert ferrous to ferric, it can oxidize the ferrous form to ferric form so that it can be transported by transferrin in the plasma. Iron can move from one place to another place. Copper binding ATPase, please remember, copper binding ATPase, this enzyme's primary function is to go for excretion of copper into bile. What does this enzymatic activity do, beta? Excretion of copper into bile. Excretion of copper into bile. Please try to focus on this one, beta. Excretion of copper into bile. So please remember this, beta. Excretion of copper into bile. And if this is deficient, if ceruloplasmin is deficient here, beta, so what will happen? Both these functions will be lost. And if the second function is lost here, beta, what will happen? The copper, which normally should come out of liver and it should go out via bile so that it can pass out through stool, if this journey is blocked because this ATPase enzyme is not able to work because there is a gene mutation of ATP7A, so ultimately what will happen? Copper will not be able to excrete out and copper will be stored. Copper excess, ultimately it will lead to copper storage, beta. It will ultimately lead to copper storage. Important point to be noted. Copper storage, beta. It will lead to copper storage and ultimately hepatocellular degeneration, liver, then basal ganglia, lenticular degeneration, then the eye changes in lens. Right, beta ji? Important point. What about the first one, beta? ये तो ठीक है. What about the first one? Can somebody come up with the answer of this? COL1A1 gene mutation leads to which disorder, beta? Answer, 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 beta जी. आंसर बेटा, आंसर. हेलो, कहाँ गए आप लोग? यस, आंसर बेटा. यस, फर्स्ट वन ए इज द आंसर फॉर व्हाट बेटा? कोलाजेन 1A1 जीन म्यूटेशन. यस, ट्राई करो बेटा. दिस इज ऑल्सो is an important point beta. Collagen 1A1 gene mutation. Collagen 1A1 gene mutation beta. 1A1 gene mutation. Is somebody coming up with the answer? Please write down beta. This is actually for osteogenesis imperfecta. Yes, Ritvika Rajput. Yes, Ritvika Rajput. Yes beta, you have correctly answered. Himanshu. Yes, yes, please beta, osteogenesis imperfecta. Please remember, collagen 1A1 gene mutation. Type 1 collagen is also actually found in our bone beta, non-cartilaginous connective tissue like bone. Please remember, osteogenesis imperfecta. Collagen 1A3 and collagen 1A5, both these gene mutations are also seen in Ehlers-Danlos syndrome beta. Ehlers-Danlos syndrome, where we have stretchable skin and all those things. Please remember, osteogenesis imperfecta, also known as brittle bone disease, where there is frequent fractures in bone. So collagen 1A1 and collagen 1A3 beta. Not scoliosis beta ji, not yeah, scoliosis is one of the features. Yes beta, yes Jivita, correct beta. Scoliosis is one of the features, but particularly the disorder is osteogenesis imperfecta. Yes, Alina. Yes, Ehlers-Danlos. Yes, collagen 1A3 as well as 1A5, both beta. 1A3 as well as 1A5. Both these gene mutations are actually seen here. Right, beta ji? Important point to be noted. Yes, let us move further. इसको ध्यान दो. Next question, read the last line first. Which of the following defect in DNA repair mechanism would best explain the condition? So basically we have to first identify this condition beta. 14-month-old child, look for positive findings. 14-month-old child, OPD, extreme sensitivity to sunlight, such as freckling in sun exposed area. There are so many cracks which are appearing, freckling in sun exposed areas. There is also dry skin, changes also in the skin pigmentations, changes in the skin pigmentation. Child was thoroughly worked out, diagnosed as a case of xeroderma pigmentosa. beta diagnosis bola hua hai, and it may lead to skin cancer, all of you know. So answer yes beta, all of you, yes, all of you have marked it correctly beta, all of you have marked it correctly. Clap for you beta, great. Xeroderma pigmentosa is due to a defect in nucleotide excision repair beta. Nucleotide excision repair, yes, you are correct. Nucleotide excision repair defect, it is a type of DNA damage repair. If this DNA damage is not getting repaired due to nucleotide excision repair defect, it leads to xeroderma pigmentosa. Diagnosis bola hua hai, simply they have asked about what is the defect, right beta? Let us quickly see what are this DNA damage repair. DNA repair mechanism, whenever there is a damage, it should be repaired ideally. No need to look for all these 6 things, you might not be able to remember all those. Just try to focus on the main important points. NER defect, NER defect is seen in xeroderma pigmentosa beta. MMR mismatch repair, इसको शॉर्ट में हम लोग ये भी बोलते हैं mismatch repair. MMR strand directed mismatch repair, full name. MMR we have seen in defect leads to HNPCC. Which is HNPCC? Hereditary non-polyposis colonic cancer beta, which is also known as Lynch syndrome. We have Lynch 1 and Lynch 2. No need to go into detail, just try to remember these two. And please remember the last one also beta, transcription coupled repair defect leads to Cockayne syndrome beta. Please remember these 3 beta ji. Please remember these 3 beta. Xeroderma pigmentosa, nucleotide excision repair. Lynch syndrome or HNPCC, mismatch repair. Cockayne syndrome, transcription coupled repair. If these DNA repair mechanisms are defective, please remember, if these 3 are defective, this is gone, second one MMRB is gone, and the 6th one, if these 3 are gone, then they will lead to these disorders, right beta ji? Important point to be noted. HNPCC, yes beta, HNPCC is hereditary non-polyposis colonic cancer, right beta ji? Important point to be noted. इसमें सिर्फ 3 चीजें याद रखने हैं, 3 DNA repair defect, 3 different disorders, right beta? Important point to be noted beta. Now small question, we can start reading it from the first. Malignant carcinoid syndrome, already diagnosis told. Huge increase in the production of 5-HT with ratio change of 1:60 as compared to the normal individual. Which of the following compound is most likely to be excreted in urine to aid diagnosis? So basically they have asked about beta, how we can diagnose a case of malignant carcinoid syndrome. Important point to be noted beta. आंसर बोल लो बेटा, इसका आंसर बोलो. yes बेटा, yes. निधि, अरमान, सुषमा, सलीम, अफसल, सुजीत, सुनील, नावी. great बेटा, great. The answer to this question is this one बेटा जी. आंसर इसको मार्क कर लो, मार्क करो इसको बेटा. 5-HIAA, 5-hydroxy indole acetic acid. In short we call it as HIA. 5-hydroxy indole acetic acid. What is malignant carcinoid syndrome beta? Argentophenoma. All of you would have heard about this beta, Argentophenoma. Important point to be noted beta, Argentophenoma. Please remember, here in Argentophenoma we have overproduction of serotonin. What is this beta? Serotonin, all of you know it is a neurotransmitter, and whenever it is not needed, it is metabolized further in the liver. Serotonin in the liver by monoamine oxidase or MAO enzyme, it is converted to 5-HIAA, right? Normally 5-HIAA is produced to some extent in our liver, but whenever you have very high levels of serotonin in any disorder, what will happen? You will also will have very high levels of 5-HIAA, and this 5-HIAA after production in the liver ultimately will be channelized in urine and it will be coming out in urine. So primary metabolite, yes beta, great answer Srishti, great answer beta. Primary metabolite of serotonin, excess release of serotonin, yes beta ji, important point to be noted. Please try to remember beta serotonin. Just try to understand beta, normally if you say, normally only 1% of tryptophan actually goes for serotonin production. Please try to understand, हम लोग जो different proteins खाते हैं, whatever proteins we consume, in that we have amino acid, few of them will be tryptophan. We all know tryptophan is an essential amino acid coming from our diet. This only 1% of the tryptophan that we eat should go for serotonin production. But if in cases of Argenta phenomena, what happens beta? Not 1%, more than 1%, and even sometime up to 60% of tryptophan can be channelized for serotonin production. 1% में normal है, 60% हो गया, 60 times higher, so we will be having 5-HIAA overproduction, primary metabolite of serotonin. Great answer beta. Please remember this question. And how do you estimate it? You have to go for 24-hour urinary output collection beta. You have to give the patient a jar to collect all the 24-hour urine output. Next morning he or she should come with the jar, and we have to estimate the total amount of this metabolite, that is 5-HIAA. Right beta ji, important point to be noted. What about Figlu beta? हमने ये देखा हुआ है अभी. Figlu is actually important for diagnosis of B9 deficiency, right beta? B9 deficiency, right? 3-hydroxyanthranilic acid, not so much important, and 3,4-dihydroxyphenylalanine, not so much also important clinically, right beta? Let us see which one is this one. I was talking about tryptophan. All of you know different specialized products that can be obtained from tryptophan, like serotonin, melatonin, vitamin B3 or niacin. Just try to focus on this one beta. Tryptophan by tryptophan hydroxylase can produce 5-hydroxytryptophan, जिसको हम लोग 5-HT बोलते हैं. And please remember this, by and decarboxylation process, by the presence of B6, it can be converted to 5-hydroxytryptamine, which is also known as serotonin, that ultimately gets converted to primary metabolite, that is MAO, and this is the compound 5-HIAA. This is the normal thing. And how much of tryptophan? Only 1%. But whenever we talk about malignant carcinoid syndrome, this ratio changes to up to 60% of tryptophan entering into this particular pathway, right beta? Only 1% versus 60%, right? And in the pineal gland, serotonin further can go for acetylation and ultimately by methylation by SAM. SAM is again an important question, was also asked last time beta. Can somebody come up with the answer? Important point to be noted beta. Important point to be noted. What is SAM beta? What is SAM beta? What is SAM? What is SAM? Somebody can come up with the answer. What is SAM beta? What is SAM beta? Can somebody come up with the answer? Methyl donor. Yes beta. Great. Great. Yes. Yes. Vavin, Arman, Zain. Please remember beta, this is universal methyl group donor. Please mark it beta. Universal methyl group donor. So please try to understand beta, SAM is also important in producing melatonin from serotonin, right beta ji? Important point to be noted. S adenosyl methionine, SAM uncle, active form of methionine. SAM, important point to be noted beta, universal methyl group donor. Important point beta, important point. Please remember this question that was also recently asked. If I talk about the Argenta phenomena, most common site, please remember the mnemonic IRA. We have ileum, rectum and appendix. Please remember, as per the latest edition of Harper, as well as per the latest edition of Harrison, please remember ileum is the most common site beta. Yes, Sam uncle. Yes, Sam uncle. Please remember like this beta, Sam uncle. Right, IRA, ileum, rectum, appendix. Please remember in this order beta. Most common site is ileum beta. is ileum. Most common site is ileum. Diagnosis can be done by serum serotonin level, urinary excretion of this 5-HIAA, that is the most preferred one usually, and neuroendocrine markers that we have like chromogranin A, neuron specific enolase, as well as synaptophysin. All of you know how this carcinoid syndrome clinical symptoms, there is also flushing, and there is also intermittent diarrhea, sweating, fluctual hypertension, and we will be having pellagra like symptoms. Why pellagra like symptoms beta? Please remember, tryptophans, one of the product is niacin or B3. If majority of the tryptophan is converted towards serotonin pathway, then towards the B3 production only minor amount of tryptophan will be channelized. So please remember, carcinoid syndrome patients or argentophiloma cases, they will be also having some pellagra like symptoms, right beta? Let us move forward. Let us move forward this beta. Yes, we can read this question, not so big. 4-month old child, 4-month old child, let us read the question beta. OPD, refusal to suck breast milk, occasional seizures, secondary hypoglycemia. There is evidence of ketosis and one form of organic aciduria with normal ammonia level in blood. Normal ammonia level. Diagnosis beta. Diagnosis, yes beta, yes. Then 60 milligram of tryptophan produces 1 milligram of niacin. All of you know this. Moving to the second next question. Yes beta, answer to this question, answer to this question. Read the question carefully beta, read the question carefully. Shahana, Sushma, Himanshu, Sujit, Afsal, no, please read the question carefully. Sunil, Jivita, Alina, read the question carefully beta, read the question carefully. Navi, read the question carefully beta. 4-month old child, refusal to suck breast milk, occasional seizures, secondary hypoglycemia, evidence of ketosis. Please remember, all these features are pointing towards diagnosis of maple syrup urine disease. Please try to understand this. Maple syrup urine disease. Maple syrup urine disease. In maple syrup urine disease, basically they are occasional seizures, secondary hypoglycemia, even refusal to suck breast milk, and there is also ketosis, because in maple syrup urine disease we have deficiency of enzyme BCKD, branched chain alpha ketoacid dehydrogenase complex, right? So if BCKD is deficient, ketones will be increased, ketoacids will be accumulated, and they will cause ketosis. Please remember, this sort of similar features are also common in the option that you all were marking, multiple carboxylase deficiency. But in order to mark the answer as multiple carboxylase deficiency, along with the features of maple syrup urine disease, there has to be skin involvement beta. There has to be skin involvement, which is missing in this particular question beta. This is missing. So these are only the features of maple syrup urine disease. Please remember the correct answer to this question beta. Yes, Nitesh, Esther, yes beta. BCKD Zain, yes beta. Deepinder, yes. Now you have marked it correct. Now you have marked it correctly beta. Important point, maple syrup urine disease. Yes beta ji. Maple syrup urine disease. क्या बात है? Maple syrup urine disease. Please remember, whenever you have features of maple syrup urine disease plus skin involvement, only then diagnosis changes to multiple carboxylase deficiency. Otherwise, it is plain and simple maple syrup urine disease. All of you know other important question. What are the other important point from this disorder beta? All of you know burnt sugar smell. Yes beta, yes. Zain Khan, Sushma, thank you for understanding. Please read the question carefully beta. क्वेश्चन में ध्यान दो बेटा, 1 मिनट टाइम है, एटलीस्ट 30 seconds give it for reading questions carefully. Burnt sugar smell in urine. How do you diagnose burnt sugar smell? To all of you know burnt sugar smell is there. How do you diagnose? How do you diagnose beta? How do you diagnose beta? How do you diagnose? How do you diagnose? Yeah beta, hyperammonemia. Please try to understand in this case beta, they are telling about with normal ammonia level. I told you beta, branch chain amino acid metabolism particularly focusing on energy production, and usually branch chain amino acid metabolism may produce hyperammonemia but may not produce hyperammonemia as well. Particularly if you have the urea cycle enzyme, इसको ध्यान दो बेटा जी, इसको ध्यान दो, इसको ध्यान दो बेटा, इसको ध्यान दो, ये गॉड लेवल, ये इसको ध्यान दो बेटा, यूरिया साइकिल एंजाइम डिफेक्ट जो होते हैं लाइक CPS1 कार्बामाइल फॉस्फेट सिंथेटेज 1 ऑर्निथिन ट्रांसकार्बामाइलेज, यूरिया साइकिल एंजाइम डिफेक्ट प्राइमरली लीड्स टू हाइपर एमोनेमिया, और इफ देयर इज pathology in the liver itself, either some acute viral or acute infective hepatitis, or if you have chronic liver disease, then you have hyperammonemia chances more. But in this case, please try to understand, as we have organic aciduria due to presence of keto acids that leads to ketosis, but not with high level of ammonia. So please try to understand this beta, please try to understand this beta, important. This is maple syrup urine disease diagnosis. We can go for, one is burnt sugar smell, and the important question, please remember, important question, important question beta, please remember, yeah beta, normal ammonia, BCKD deficiency or maple syrup urine disease may or may not present with hyperammonemia, right beta. Diagnosis, diagnosis, please remember a test known as DNPH test beta, please write it down beta, डाइनाइट्रोफिनाइल test, इसको ध्यान दो बेटा, डाइनाइट्रोफिनाइल, प्लीज रिमेंबर बेटा जी, क्लासिकल क्वेश्चन, DNPH टेस्ट, डाइनाइट्रोफिनाइल टेस्ट, इसको मार्क कर लो बेटा जी, इसको मार्क कर लो, डाइनाइट्रोफिनाइल टेस्ट, DNPH टेस्ट, DNPH test is classically done for maple syrup urine disease. Maple syrup urine disease. Please remember the clinical features. Usually it presents in the first week of life, but there can be some late presentation. If it presents during the first week of life, it will present with hyperammonemia. But as it is a late presentation here, 4 months, not in the first week of life, so liver is now developed, liver can handle detoxification of ammonia. So in this case, actually we have normal ammonia level. Please try to understand this important point beta. Although maple syrup urine disease cases can present with hyperammonemia, but those presentations are during first week of life. Late presentation, liver is getting 4 months time to get somewhat mature. Now liver can handle ammonia, can convert it to urea. So hyperammonemia chances are decreased here. Important point to be noted. अगर ये same question आता और अगर बोलता कि 1 week old child, then they would have definitely mentioned it with hyperammonemia. 4 month old, liver matured to some extent, normal ammonia level, but disease remains same. Maple syrup urine disease, maple syrup urine disease, DNPH test, DNPH test, maple syrup urine disease. DNPH test, maple syrup urine disease, right beta. Moving to the question number 10 beta, hope you are able to get these points. Small question, we can definitely read it. 40-year-old male, CEO MNC, MNC means multinational company, mostly leading a sedentary lifestyle. Look for positive findings beta. Experiencing dyspepsia and occasional epigastric pain beta. Please try to mark the important clinical findings beta, positive findings beta, positive findings, ध्यान देना है इसको. USG revealed stage 2 fatty liver. Basically they have told you the diagnosis itself beta, sedentary lifestyle, experiencing dyspepsia, stage 2 fatty liver. Now all of the following are considered beneficial in preventing fatty liver except, ये जो एक्सेप्ट वाले क्वेश्चंस होते हैं इसको हमेशा ध्यान देना है बेटा. प्लीज रीड द क्वेश्चन केयरफुली. सो बेसिकली दे हैव आस्क्ड यू अबाउट what are the things they can prevent fatty liver except. All of us know the compounds which prevent fatty liver are known as lipotropic factors. Please remember beta, they are known as lipotropic factors. Please remember, what are lipotropic factors? They prevent fatty liver. they prevent fatty liver. Please try to understand here beta. Lipotropic factor prevent fatty liver. How do they prevent fatty liver beta? Please remember, all of us know beta, isko dhyan do beta, all of us know they actually carry triacyl glycerol or triglyceride away from the liver beta. They will carry TAG away from the liver. They will not allow the TAG to get deposited in the liver. How fatty liver is basically done? What is the most common culprit in India to cause fatty liver in all of us? If some of us gets our USG done right now, many of us might be already having fatty liver, either stage 1 or stage 2. We do not know. We are still living our normal life. Please remember, the most common culprit in India is our carbohydrates. Carbohydrates. Exogenous carbohydrate can get converted to endogenous fat in the liver, which comes out of the liver in the form of very low density lipoprotein or VLDL. These fats are produced in the liver, gets deposited in the liver. So we need our lipotropic factors which can carry these TAG or triglycerides away from the liver, and they are known as lipotropic factors. Let us quickly see this. What are these lipotropic factors? As I told you, what are they? They carry or transport or carry TAG और ट्राइग्लिसराइड्स अवे फ्रॉम लिवर बेटा, इसको लिख लो बेटा, अवे फ्रॉम लिवर. ये लिवर के तरफ टीएजी को जमा होने नहीं देता है. व्हेनेवर वी हैव एनी प्रोडक्शन ऑफ टीएजी इन द लिवर, और जब भी हमारे लिवर में ट्राइग्लिसराइड प्रोडक्शन होता है, इसका काम है उसको बाहर निकाल देना ताकि हमारे लिवर में टीएजी ना जमा हो पाए. राइट बेटा जी, इंपॉर्टेंट पॉइंट. इट डजंट अलाउ the TAG to get deposited in the liver beta. Important point to be noted. Please remember, these are the all the names of lipoprotein factors. We have a actually lot of names beta in this. Please remember the most important ones. In books you might find many others. I'm not going into the detail. Just try to understand. We have choline betaine. Please remember these two names, very very important. प्लीज रिमेंबर बेटा, विटामिन ई एंटीऑक्सीडेंट एंड सेलेनियम, इसको भी याद रखना है बेटा. सेलेनियम ऑल्सो इज ए लाइपोट्रोपिक फैक्टर्स. हाउ कैन वी फॉरगेट आवर सैम अंकल? प्लीज रिमेंबर आइदर मिथियोनिन और सैम अंकल. सैम अंकल ऑल्सो इज प्लेइंग ए रोल इन दिस वन. सैम सेरीन ग्लाइसिन. वी हैव 4 इंपॉर्टेंट विटामिन्स बेटा, particularly B6, B9, B12 and also B5. We have inositol, lecithin, essential fatty acid and PUFA or polyunsaturated fatty acid. All these things, they can actually act as our lipotropic factors. Ritvika, yes, you have marked the answer correctly. Ritvika Rajput, yes beta ji. Question क्या था? Except. So arginine here becomes the answer beta. Please mark it beta. Arginine is not a lipotropic factors beta. Important point to be noted beta. Important point to be noted beta. Choline, betaine, lecithin, these are there. Choline, betaine, lecithin, these are there. Arginine is not important as a lipotropic factors beta. So option number D is the correct answer. Question was except. Let us quickly see one more time beta. इसको याद रखना हो बेटा, मेरे साथ एक बार रिपीट कर लो बेटा. हेलो बेटा जी, एक बार इसको रिपीट करो मेरे साथ. Choline, betaine, vitamin E, selenium, samserin, glycine, B5, B6, B9, B12, inositol. Yeah beta, the link was I think dropped in between, so let me repeat it one more time beta. How do we remember these lipotropic factors? Let us see it one more time beta ji. Let us see it one more time. We have choline, betaine, vitamin E, selenium, samserin, glycine, B5, B6, B9, B12. We have inositol, lecithin. At least try to remember this. Last row we can even forget this. Last, essential fatty acid and PUFA. An important point to be noted beta, vitamin E and selenium, they are synergistic to each other. Whenever we have any deficiency of vitamin E beta, please try to understand, if we have enough selenium present in our body, we can still counter some effects of vitamin E deficiency, and same goes with selenium deficiency. If you have a case of selenium deficiency and if you have optimum vitamin E level in your diet, then please try to understand, we can also counter the effects of selenium deficiency. So though they are helping each other, E deficiency selenium will help, selenium deficiency vitamin E will help. So they are synergistic to each other. What is the deficiency of selenium beta is known as, बेटा जी इसका आंसर करो. If selenium is deficient, ये क्वेश्चन भी आता है बहुत बार. If selenium is deficient, if selenium is deficient, कौन सा डिसऑर्डर होता है बेटा? If selenium is deficient, which disorder? Yes beta, Khashan disease. Khashan disease, we have selenium deficiency, right? Khashan disease. Also we have one more associated known as Kashin-Beg disease. Two disorders are there. What about vitamin E deficiency beta? Please remember, vitamin E deficiency, please try to understand, this causes hemolytic anemia in the newborn. Hemolytic anemia in newborn, इसको मार्क कर लो बेटा. And if by chance they ask you about vitamin K deficiency, they cause hemorrhagic disease in newborn. Hemorrhagic disease in newborn, right beta ji? Important point, please try to remember beta. Vitamin E, hemolytic anemia, important point beta ji. Yes, most potent. Yes beta, hemolytic anemia in the newborn. We all know this is the most potent antioxidant out of all those antioxidant present. Vitamin K, hemorrhagic disease in the newborn beta, hemorrhagic disease in the newborn, vitamin K deficiency. Vitamin E deficiency, hemolytic anemia in the newborn. Yes, great beta, great Bhavin, great Jivita. Yes Suji, thank you Jivita. Arman, thank you beta. Yes, moving further. Great. Yeah, what is the most likely diagnosis? Basically we have to now read the question carefully. They have straight away asked about diagnosis. First try to focus on positive findings: infant, pediatrics OPD, joint pain, around knee, bulged out abdomen, thin extremities, increased appetite, hepatomegaly, xanthoma over his back and thigh region, and doll like faces with fatty cheeks, fatty infiltration of the liver, and acidosis on ABG. Bhai, iska diagnosis, I believe all of you who are joining me live today, they will be able to answer. Yes, yes, yes. Clap to all of you, beta. All of you have marked this correctly, beta. Great, great, beta, great. This is von Geerk's disease, beta. Please remember, frequently asked question. All the positive findings are given in this MCQ. You can never go wrong in marking the answer as von Geerk disease. Right, beta ji? C, von Geerk disease. Yes, beta. Great, great, great. Von Geerk disease, most common beta. All of you know this. Most common glycogen storage disorder overall, as well as in children. Please try to understand this beta. Most common glycogen storage disorder out of all the types that we have studied, most common is von Geerk disease type 1A beta. Von Geerk disease type 1A. One has further 4 subtypes: 1A, 1B, 1C, 1D. 1A is known as von Geerk's disease. This is most common. Let us quickly see important findings of this von Geerk disease one more time beta. As I told you, the reason I am sharing this here as well beta, this is important. इसको ध्यान देना है बेटा, इसको याद रखना है, भूलना नहीं है. Highly likely this question will be asked, sir. Please remember, just important findings of von Geerk disease. Von Geerk's disease. Let us quickly write down this one beta. We have two sort of presentations. We have early presentations and we have late presentations, right beta? Early presentations, basically we talk about the first 28 days of our life. Late presentation means minimum 3 months to 4 months, right beta ji? Two ways they can present. First important point, मोहम्मद रज्जाक, नो बेटा G6PD, नो दिस इज नॉट द G6PD डेफिशिएंसी बेटा जी, हेलो इसको ध्यान दो बेटा, रज्जाक इसको ध्यान दो बेटा, दिस इज नॉट G6PD डेफिशिएंसी, आई होप ऑल ऑफ यू नो दिस। वॉन गियक डिजीज, दिस इज ग्लूकोज 6 फॉस्फेटेज डेफिशिएंसी बेटा, इसको भूलना नहीं है, ग्लूकोज 6 फॉस्फेटेज, ग्लूकोज 6 फॉस्फेटेज डेफिशिएंसी बेटा। G6PD deficiency, glucose 6 phosphate dehydrogenase deficiency, that is different, most common cause of your hemolytic anemia in India, that is G6PD deficiency, right beta, वो different question है। Von Gieck disease is a glycogen storage disorder, most common type, this is glucose 6 phosphatase deficiency beta, glucose 6 phosphatase, right beta, important, not G6PD, yes, then this is G6P, glucose 6 phosphatase, not phosphate, phosphate is the yeah, hope you're able to follow this. Yeah, two presentation, first one that we have here is beta fasting hypoglycemia, write it down beta ji, fasting hypoglycemia, and particularly this fasting hypoglycemia is noted in between meals, please remember this beta, in between meals, very very important, all of us know glycogen is the predominant compound which basically tries to maintain our blood sugar level whenever we are not eating, and glycogen alone is sufficient enough to counter any fall of blood sugar level for 0 to 18 hours, right? So fasting hypoglycemia will be there because glucose 6 phosphate is not able to get converted to glucose, so we are not getting glucose, blood sugar is not maintained, and we will be having hypoglycemia, and this is actually affecting in our liver, right beta ji, in hepatic glucose 6 phosphatase, in hepatic glucose 6 phosphatase beta, fasting hypoglycemia in between meals. Second one, we will be having lactic acidosis, I'm just quickly summarizing the most important point. Then we have hyperlipidemia, we have hyperlipidemia beta, hyperlipidemia, please remember this, hyperlipidemia, followed by there will be also ketone body overproduction, ketosis, and please remember beta hallmark finding, hyperuricemia or gout like picture, important point, gout in a neonate, gout in a neonate, gout in a neonate, please remember. First thing that should strike in your mind beta ji, that it might be a case of वॉन गियर्क डिजीज, भूलना नहीं है इसको, इंपॉर्टेंट पॉइंट, हाइपर यूरिसीमिया, इंपॉर्टेंट पॉइंट टू बी नोटेड, राइट बेटा जी। व्हाट आर द लेट फीचर्स दैट वी हैव बेटा, व्हाट आर द लेट फीचर्स दैट वी हैव, लेट feature that we have beta, please remember we will be having hepatomegaly, there can be also your kidney enlargement, there can be also kidney enlarged, please remember we will be also having xanthomas whenever we have hyperlipidemia, deposition of the lipid little cells underneath our subcutaneous tissue, splenomegaly can also be there to some extent, and please remember most important beta, doll like faces, doll like faces, please try to understand beta, doll like faces simply means you have chubby cheeks, you have chubby cheeks, right beta ji, important point to be noted beta, chubby cheeks, important point, right beta, please try to remember this. Von Gieck disease, important clinical features, important point, great beta, right? If somebody is noting it down, please note it down quickly beta ji. Yes, so these are the important features of von Gieck's disease, von Gieck disease, right beta, von Gieck's disease, right, von Gieck disease, great, great, these are the features beta. As you can see in this image based question can also be asked, look at the abdomen beta, look at the span of the liver beta, almost total width of this particular child, we basically have this pot belly, this protuberant abdomen, we have this pot belly, that was also there in the MCQ, that was given, pot belly, enlarged abdomen, enlarged abdomen, please try to understand this beta, pot belly, and this particular image, please remember This is doll like faces beta. Particularly this is doll like faces. Particularly this is doll like faces beta, right? Important point to be noted, doll like faces. Yes. Going on, please remember, most likely diagnosis question they have asked on most likely diagnosis. We have to read the question carefully. 19-year-old college student comes to health clinic complaining of muscle aches. Began an exercise program to lose weight. First day of weightlifting, extremely sore. Several hours later, urine the color of cherry soda pop. Physical examination unremarkable. Laboratory test with high elevated serum creatine kinase level. Negative for blood, positive for myoglobin. Answer, beta ji. Answer. Yes, yes. Jayashree, Shushma, Omkar, Gaura, Shubham, Himanshu, Navi, Praveen, Doctor, and Esther. Please remember, all of you have marked it correctly. Diagnosis is beta McArdle's disease. McArdle disease. What is this? Most common glycogen storage disorder in adult, right beta? Most common glycogen storage disorder in adult, right beta ji? Important point, McArdle disease. Please remember, cherry soda pop, positive for myoglobin, positive for myoglobin. Exercise program. Please remember, exercise, cherry soda pop, cola color urine, positive for myoglobin. This is also sometime given in your MCQs as exercise induced myoglobinuria. Exercise induced myoglobinuria. All of you will remember this beta. Important question. Exercise induced myoglobinuria is a feature of McArdle disease. What is McArdle disease? This is the type 5. Type 5. Yes beta ji. Yes Rahul, you are correct. Exactly, type 5. Most common. Himanshu, correct. Most common. Exercise induced myoglobinuria is a feature of this. And please remember, in these patients, as we require heavy ATP need because we are doing some weight lifting and all these things, please try to focus here. As we are doing this weight lifting and all these things, please remember, our body's muscles creatine phosphate also will be activated, and that will also get channelized more and more to release more and more ATP by creatine kinase level. So in this patient, there will be also elevation in the CK3, creatine kinase, or CKMM, that is found in our isoenzyme in muscle. CK3 or CKMM also will be increased beta. It will be also increased, right beta ji? Important point to be noted. Yes, important point to be noted. Muscle glycogen phosphorylase. Yes, correct beta. M for M, all of you know. M for M. H is Hirsch disease, hepatic glycogen phosphorylase. All of you know this. Let us move forward. Yes, next important question. Most likely diagnosis. Need to read the question carefully. Mr. X, 46-year male, OPD, low back pain, painful urination, normocytic normochromic anemia, hypercalcemia. Bradshaw test come positive, but heat test come negative. Serum protein electrophoresis done that shows the following. This is the important finding that is given in this image. Please try to understand diagnosis. Yes beta ji, all of you, Nidhi, Sushma, Jivita, Krupa. No, Krupa, the answer is not A beta, answer is B, Krupa. It answer is B beta. Sujit, Umapati, Himanshu, clap for all of you beta. Afsal, yes. Multiple myeloma beta. Yes, the diagnosis here is multiple myeloma. What is multiple myeloma beta ji? Please remember, multiple myeloma is actually a neoplastic change of the B cell lineage. Neoplastic changes. Important point to be noted. And please remember the most important clinical features of this. We can remember it by the mnemonic CRAB. What is CRAB? C say we have hypercalcemia, hypercalcemia. R say we have renal stones. A say we have anemia. And B say we have lytic bone lesions. Please try to understand here, beta. Lytic, yeah, I hope you're able to see. Yeah, you're able to see it here, beta. CRAB is the mnemonic. Four things: calcium increase, renal stones, anemia, and lytic bone lesions. Lytic bone lesions, beta. Please remember, CRAB is the mnemonic, and all these are actually found in this patient. We have low back pain. Low back pain particularly might be due to these lytic bone lesions. Please remember, we have painful urination, that is due to these renal stones, normocytic normochromic anemia, and we have hypercalcemia. All these features are actually given in this patient. And please try to understand here, beta, osteolytic bone lesions that we have, all these are pointing towards multiple myeloma. Now also try to understand here, beta, we have actually two tests that can be done to diagnose this. We have something known as this Bradshaw test, and something known as heat test. Two tests can be done as a screening test. Please remember why we can do this test. In multiple myeloma patients, we have a special type of protein that is actually produced more and more. Please try to understand here, beta. If you look at these plasma proteins, we basically have albumin, alpha 1, alpha 2, beta, and the gamma. In the gamma section of our serum protein electrophoresis, basically we have immunoglobulins. From the immunoglobulins, please remember one such immunoglobulin is IgG. And please try to understand, beta, in cases of multiple myeloma, there is overproduction of this immunoglobulin IgG. And this IgG, whenever it is overproduced, please try to understand, this immunoglobulin comes out separately as a fraction, and in the serum protein electrophoresis, beta, we have something known as M band. Or myeloma band or monoclonal band in serum protein electrophoresis. Please try to write down here, beta. There will be M band or myeloma band or monoclonal band seen in serum protein electrophoresis, beta. What happens, beta? The gamma fraction in the electrophoresis is actually made up of all the immunoglobulins. They are all falling under gamma. But as in this multiple myeloma patient, we have overproduction of immunoglobulin here. This immunoglobulin G in particular, only one fraction, this monoclone single type, here it is overproduced so much that it actually comes out of the normal band, and it creates a separate band between this beta and the gamma. So please remember, overproduction of immunoglobulin G is the main reason for production of M band or myeloma or monoclonal band. IgG is overproduced here, beta. IgG. We all know immunoglobulins are actually made up of, beta, light chains and heavy chains. And here actually we have disproportionate production of alpha chains and the light chains and the heavy chains. In the light chains, we basically have kappa and lambda both kappa and lambda is increased, and there is a disproportionate production as compared to the heavy chain. So they cannot bind with the heavy chain, so they become free. They do not have that many heavy chain to bind with them, as lambda and kappa are so high. So what happens? They do not have heavy chains to bind with them. So these extra lambda or extra kappa chains now comes out in urine, and in urine basically we give them a classical name, beta, that is known as Benz Jones protein, right, beta G? Yes, Ridvika, Yes, please try to understand here, beta. Important point to be noted. Important point to be noted. This is known as Benz-Jones protein. What is this Benz-Jones proteins? Let me just quickly write it here, beta. Benz-Jones protein. Frequently asked question. Benz-Jones protein. Benz-Jones protein. Important point to be noted, beta. This is actually due to the light chain overproduction. This is the light chain overproduction. Particularly both we have kappa and lambda. If you have to choose one answer between them, all of you happily go with the answer of lambda, beta. Please remember, lambda is more important than kappa, but there is overproduction of both kappa and lambda, right? But there is disproportionate. Kappa and lambda are overproduced, but heavy chains we do not have more. So there is disproportionate production. Kappa and lambda have no one to bind with them. They are free. Comes out in urine. Benz-Jones protein, right, beta? And this Benz-Jones protein, please remember, beta, this is actually an acid meta protein. This is an acid meta protein, and due to this, basically it forms a whitish color ring in the Bradshaw test. And during the heat test that was mentioned in the question, beta, during the heat test that they have mentioned in the question, please remember, it has a peculiar property of precipitation, only between 45 degree to 60 degree centigrade. Question also may come like this, beta. One particular protein that is precipitated only between 45 degree to 60 degree centigrade, but it is dissolved less than 45 degree, but more than also 60 degree, it is also dissolved. Diagnosis will be Benz-Jones protein, beta. Please remember, Benz-Jones protein, please write down this important point, beta. They are precipitated, please write it down, beta. They are precipitated only between 45 degree to 60 degree centigrade. Less than 45 they are dissolved, more than 60 also they are dissolved, only between this. Carefully, if you increase the temperature, only you will be able to see the precipitation, beta. This is the property of heat test. If you heat this urine sample between 45 to 60, precipitation. Keep the temperature below 45 or more than 60, no precipitation. So initially no precipitation. Precipitation appears between 45 to 60 degree on heating the urine sample of multiple myeloma patient, but after 60, beyond 60, again dissolved. Diagnosis, multiple myeloma. But confirmatory test is neither this Benz-Jones protein nor this Bradshaw test. Please remember, the confirmation is done by serum protein electrophoresis. If by chance they ask you, beta, hallmark, best way to diagnose a case of multiple myeloma, this is serum protein electrophoresis. That is the gold standard, beta. Serum protein electrophoresis. And in serum protein electrophoresis, what you have to look for? Additional band, monoclonal band, myeloma band, M band. Question may come, due to which immunoglobulin? Answer is immunoglobulin G. This immunoglobulin G will come out as a separate band, M band or monoclonal band, right, beta? So multiple myeloma may be asked as an important clinical question for you in your exam. Please try to read about this, beta. Serum electrophoresis, yes, beta. Jivita, answer correct. Serum electrophoresis, serum protein electrophoresis, important point, right? This we have done over there itself. Important point of multiple myeloma. Short question, we can happily read it, beta. Important point to be noted. Mr. X, 66-year-old male, accompanied by his wife, for recent incidents of forgetfulness frequently. Senile dementia was identified and diagnosis of Alzheimer's disease was made. Diagnosis Alzheimer. Which of the following is most unlikely? बेटा जी क्वेश्चन को ध्यान देना है. Most unlikely to be associated with the said condition. Answer. 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 बेटा क्वेश्चन को ध्यान दो बेटा, प्लीज 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 बेटा, क्वेश्चन को ध्यान दो. क्वेश्चन क्या पूछा है? मोस्ट लाइकली नहीं पूछा है. क्या पूछा है? क्वेश्चन है अनलाइकली बेटा, क्वेश्चन इज अनलाइकली, इसको ध्यान दो। अनलाइकली अनलाइकली अनलाइकली, डॉक्टर अरमान, यस यू आर करेक्ट। पॉल, प्रवीण कुमार, उमापति, सुषमा, अलीना, ग्रेट। ओमकार, रीड द क्वेश्चन केयरफुली, ग्रेट बेटा। मयूर, yes, now you are correct beta, now you are correct. Please remember A, B and C, all these three are actually seen in cases of Alzheimer's disease beta. Please try to follow this. Hyperphosphorylated tau proteins, that is main culprit behind neurofibrillary tangles. ApoE4, apoprotein E4, yes, it is associated with Alzheimer's. More ApoE4, more chance of Alzheimer's. And beta amyloid precursor protein or amyloid beta deposits, all these three are positive. Answer question, unlikely lipoprotein A is not associated with Alzheimer's disease beta G. Important point to be noted. Read the question carefully. Lipoprotein A is the answer here beta. Lipoprotein A, where it is associated, what is this beta? Can somebody come up with the answer about lipoprotein A, where it is important? Okay, Alzheimer's में नहीं है, but why, where they are important? Trending topic, so many latest journals, latest articles, latest studies are done on lipoprotein A. Why beta? What is the important relation of lipoprotein A in human being? Is it a good thing or bad thing? Good thing or bad thing beta? It is a bad thing. Lipoprotein A is not at all a good lipoprotein. Please remember, if you have increased level of lipoprotein A, no beta, not Parkinson's beta, not Parkinson's. Lipoprotein A bad beta. Why bad? Please remember, we have increased chance of atherosclerosis. Increased chance of atherosclerosis. Increased chance of myocardial infarction. Increased chance of any other cardiovascular disease, even coronary artery disease, or even our diabetes mellitus. Please try to understand this beta. Lipoprotein, yes, increased chance of CVA or stroke. Great beta ji. Yes, yes Srishti, yes. Please try to understand. HDL is good. We are talking about lipoprotein A. That's the reason it is also known as little rascal beta. This is also known as little rascal. Little rascal because more lipoprotein A, because this is actually plasminogen analog beta. In vivo fibrinolysis process is damaged. It is having similarity with the plasminogen structure. As plasminogen structure is similar with lipoprotein A now doesn't allow the plasminogen activation. What does plasminogen do? Plasminogen gets activated to plasmin, that basically breaks the fibrin, right beta? That's how clot lysis happens in our blood. Now in presence of lipoprotein A, as it is looking like plasminogen, it will act as a competitive inhibitor to plasminogen. Now what will happen? As it is competitively inhibited by lipoprotein A, plasminogen can't be converted to plasmin. As there is no plasmin, no fibrinolysis. No fibrinolysis means no clot lysis. No clot lysis means clot will be floating here and there. There is high chance of thrombosis, high chance of atherosclerosis, high chance of ischemia to the heart, leading to myocardial infarction beta. So please remember, unfortunately in Indian population, we still now do not know why. So many studies are still going on with beta. But Indian population, we have higher levels of lipoprotein A. It has been found, it has been documented in so many recent studies. Lipoprotein A is dangerous for us because high lipoprotein A, high chance of MI, high chance of heart attack, high chance of stroke. Right beta ji? Important point. Question number 15. Short question. Read it carefully. ध्यान दो बेटा. 36-year-old male, OPD, personality changes, anxiety, depression, memory loss. Workup revealed the case to be a form of prion disease noted in human. They have already told you the diagnosis, prion disease beta. Most likely condition. Answer bolo. Answer. Yes. All of you are correct beta. Manasi, Nidhi, Umapati, Sushma, Nisha, God level doctor. Great beta. Great. Please try to, yes, Chinnaswamy, Ginny, Urvashi, Jivita. Yes, Zain, all of you. Great, beta. Clap for all of you. Yes, the answer is Creutzfeldt-Jakob disease, beta. We all know Creutzfeldt-Jakob disease is the most common. Creutzfeldt-Jakob disease, sorry, is the most common prion disease in human. Most common prion disease in human. Please remember, the first two, they are not prion disease, beta. Alzheimer's, Parkinson's, they are not prion. Last two, they are prion. We have to choose a better answer. मोस्ट लाइकली, ये जो सब सारे वर्ड्स होते हैं, मोस्ट लाइकली, इसको ध्यान देना है बेटा. मोस्ट लाइकली मतलब मोस्ट कॉमन, डायरेक्टली नहीं पूछ के मोस्ट लाइकली पूछा गया है. आंसर विल बी क्रूसफेल्ड जेकब डिजीज. हियर वी ऑल नो दिस इज अ टाइप ऑफ ट्रांसमिसिबल स्पॉन्जिफॉर्म एनसेफेलोपैथी. Transmissible spongiform encephalopathy. Encephalopathy. Transmissible spongiform encephalopathy. And what happens here, beta? Our cerebral cortex becomes like sponge. They will look like sponge, beta. So that's why it is known as beta spongiform. राइट बेटा जी, इसको ध्यान देना है बेटा, इसको लिख लो. cerebral cortex is the affected organ in Creutzfeldt-Jakob disease, and the personality changes, obviously CNS symptoms will be there beta. Cerebral cortex becoming like sponge, encephalopathy will be there, memory loss, depression, anxiety will be there, early changes, anxiety and personality changes, late features, they can also go for depression and ultimately memory loss. So in prion disease cases also there can be dementia, but please try to understand beta, these are not senile dementia. Prion disease cases are not usually seen during the adult, during the old age, only during the young patient. Maximum up to 40-45, all cases of prion disease, they actually presents to the OPD. Late presentation of prion disease beyond 45-50 do not happen. Basically at the age group of 25, 30, 35, 30 to 40, these are the age groups where prion disease is basically noted. Right, beta ji? Important point to be noted. Fatal familial insomnia is another form of prion disease. Right, beta? What are prion disease? I told you, prion disease are proteinaceous infective particle. They have normal primary structure but abnormal tertiary structure. So there is a problem in protein folding. Right? Alzheimer's, Parkinson's, in both of them protein folding process is affected, abnormal folded proteins are seen, but they are not prion disease. Right, beta? Alzheimer's, Parkinson's, protein folding damages, defects are seen, but not a prion. Creutzfeldt-Jakob, fatal familial insomnia, Kuru, and GSSD, Justman-Stroessler-Scheinker's disease. These are the 4 disorders seen in human being that are prion disease. Right, beta? 14-year-old boy, छोटा क्वेश्चन है, इसको पढ़ सकते हैं हम लोग. 14-year-old boy. Yes, God level doctor. Usually the prion disease, once it is diagnosed, beta, very difficult to manage this patient. Usually they do not survive. You are correct, beta. Very difficult to manage this. Usually they do not survive, beta. Next question. 14-year-old boy, OPD, frequent fractures in. Great, beta, great. All of you have marked it correctly, beta. Yes, the answer, undoubtedly, unequivocally, definitely the answer is osteogenesis imperfecta, brittle bone disease, frequent fractures in bone for which usually treatment is not required. No need to apply splint. Frequent fractures, brittle bone disease, easily fracturable bone, brittle bone disease, osteogenesis imperfecta, collagen 1A1 gene mutation, kyphoscoliosis, bowing of leg, frequent fractures, deformed teeth, blue sclera. Important point. Homocystinuria also presents with blue sclera, but no problem in the bone much as compared to the osteogenesis imperfecta. Please remember, in homocystinuria also you have blue sclera, but please remember the other features are not matching with that. Diagnosis here is osteogenesis imperfecta, type 1 collagen defect. Please remember, homocystinuria is a different disorder in the protein metabolism. Ehlers-Danlos syndrome, the features are different: hyperextensible skin, hyperstretchable skin. They can pull their skin like this. They can pull their skin like this, beta. Important point to be noted. And Marfan syndrome, basically we have other features. The mnemonic Marfan you would have already studied, not going into the detail. Cardiac involvements are also seen, like mitral valve prolapse is also seen in Marfan syndrome. So please try to understand. Osteogenesis imperfecta, yes, to some Chinnaswamy Murli, yes, some patients of OI can also present with deafness, but deafness is usually a late feature, beta. But yes, deafness can also be there, particularly a type of sensory neural hearing loss, as SNHL type of deafness can also be there in case of osteogenesis imperfecta to some extent, right, beta? Yes. Straightforward question, short question. Let us carefully read the question, beta. ध्यान देके पढ़ो, don't jump, read it carefully. Few days after birth, infant lethargic after breast milk, refuses breast milk, vomits, however accepting glucose water. क्या है इसका आंसर? अरे क्या बात है यार! All of you have marked this correctly, beta. Great, great, beta, great. All of you, undoubtedly, again the answer is beta galactosemia. Galactosemia. Yes, all of you have marked it correctly, beta. Galactosemia. Galactosemia. Great, great, great. Not D, beta. Not D. Shahana, where you have gone wrong. Shahana, Zan, not C, beta. Not C, beta. This is answer is galactosemia, beta. Galactosemia, breastfeed is contraindicated, beta. Galactosemia, it is due to the deficiency of gal1 put, that is galactose 1 phosphate uridyl transferase deficiency. Please try to understand. Galactose basically comes into the body of a child after consumption of breast milk. Breast milk we have lactose made up of galactose and glucose. As there is a problem in the metabolism of the galactose, so they are unable to digest only the galactose. Nothing wrong with glucose digestion or glucose metabolism, nothing wrong with that, because glycolysis is intact. Only problem is there is ineffective galactolysis. So don't give galactose, give only glucose, so they will accept glucose and water. So the treatment for this will be plain dextrose solution, beta, right? Galactose 1 phosphate uridyl transferase. We have a lot of clinical features, beta. Please remember, we have something known as oil drop cataract, and very important point to be noted that was also asked in your exam recently: breastfeed is contraindicated. And please remember the third important finding, beta ji, these patients, they present with unconjugated hyperbilirubinemia. Unconjugated hyperbilirubinemia. Please write it down, beta. I will just tell you one more important point related to the third point that I just now wrote. First, write down this, beta. Unconjugated hyperbilirubinemia. इसको लिख लो बेटा, इसको ध्यान दो बेटा, इसको ध्यान दो. Unconjugated hyperbilirubinemia. First, try to write it down, beta. This one, unconjugated hyperbilirubinemia. ये important है. Please remember, all these features that I have just now told you or mentioned in the MCQ, these are also seen in case of another disorder known as lactose intolerance. Another disorder named as lactose intolerance. Lactose intolerance, which is particularly due to lactase deficiency, right, beta? In that also, the clinical features almost will be similar to this, because lactase deficiency means their inability to break down the lactose itself, because lactase is not there. So also there will be problem like GI upset, flatulence, stomach pain, all those things will be there. Please try to understand. In that case also, breastfeeding usually is contraindicated. But please try to understand, in lactose intolerance cases, we do not have this unconjugated hyperbilirubinemia. This is a differentiating feature beta during galactosemia, between galactosemia and lactose intolerance. Please इसको ध्यान दो बेटा. Galactosemia and lactose intolerance, in both the cases breastfeed is contraindicated. Early presentation few days after birth is true for both. Usually galactosemia patients arrive on third or fourth day after life, third or fourth day, day 3, day 4 of the life. But lactase deficiency usually presents little late. But please remember the main differentiating feature, unconjugated hyperbilirubinemia is not seen in lactose intolerance, but it is seen in case of galactosemia. Early changes, please try to understand here beta ji. This oil drop cataract, this particular word which is true only for galactosemia, this is actually a little bit late presentation beta. But usually if the child is brought to the pediatric OPD on time without any delay, on day 3, on day 4, you might not have oil drop cataract even in a patient of galactosemia. But please remember, even the child is brought on day 3 and day 4, but still will be there unconjugated hyperbilirubinemia in cases of this galactosemia, not in case of lactose intolerance. Right beta? Important point to be noted. Srishti, no beta. Srishti, oil drop cataract is not present, but it is a late presentation. Hope your doubt got cleared. Moving to the next important question beta. 17-year-old boy presents to the OPD with stretchable skin, flexible fingers with which he can reach his forearm. Most likely condition. Answer beta. Answer to this question. Answer to this question quickly beta. Answer to this question. Yes, great. Great. Answer to this question, all of you. Yes, great beta, great beta. Please remember Ehlers-Danlos syndrome. We have just now discussed beta, flexible fingers, stretchable skin, Ehlers-Danlos syndrome, right beta? Osteogenesis imperfecta, brittle bone disease. Here we also have frequent bruising, hyperextensible skin, or stretchable skin or flexible fingers, right? All of us this we have discussed. Moving to the next question. Now, small question, we can read about this beta. 40-year-old female, senior executive, sedentary lifestyle, OPD, palmoplantar pigmentation, X-ray spine, calcification of intervertebral disc, Benedict's reagent, urine sample, greenish brown precipitate. Yes, yes beta, yes beta, yes beta, yes, yes, all of you have marked this correctly beta. Alkaptonuria, you cannot go wrong with this. Alkaptonuria is the correct answer beta. Alkaptonuria, yes beta ji. Alkaptonuria, black urine disease, all of you know the name as black urine disease. But please remember, even before black urine disease, whenever there is a color change, urine color changes on standing due to oxidation, during this journey from the normal color urine, in between for some time this will be forming something known as cola colored urine beta. Cola colored urine. And from cola colored urine they will actually become black in color. So particularly ultimate fate is black urine. In between we will be having cola colored urine. So there is a urine color changes with time. With time urine color changes on standing. With time urine color changes on standing. Diagnosis will be alkaptonuria. Deficiency of homogentisate oxidase. And homogentisate oxidase deficiency, we will be having this homogentisic acid getting increased more and more. Either they can come out in urine or they can get deposited in our soft tissues in our body. Please remember, whenever they are getting deposited in softer tissues in our body, we call it as ochronosis. Ochronosis. What is ochronosis beta? Please try to understand. Important point to be noted, ochronosis. Please remember these are all features of ochronosis. Please try to write it down beta. Ochronosis, important question. Ochronosis, black coloration of our softer tissues. Most common area is our pinna of ear beta. Most common is pinna of ear. Important point to be noted beta. There can be also underneath the palm. Underneath the palm, this is known as palmoplantar pigmentation. Palmoplantar pigmentation. Please remember most common pinna of our ear. And please remember, even in our intervertebral cartilages, in our intervertebral disc, even in these zones also, this black color pigmentation can be there. On x-ray they will look white, so they will look as zone of calcification. X-ray spine shows calcification of intervertebral disc due to ochronosis, right beta ji? Important point to be noted, ochronosis. So alkaptonuria, yes beta, over our cornea, over our lens also to some extent they can be deposited. Most common, I'm just discussing the most important beta, most common ones is the pinna of ear. Underneath the palm we call it as palmoplantar pigmentation. And as homogentic acid is reducing in nature, so Benedict test beta also is positive. Please remember bt or Benedict test is also positive because homogentic acid is actually reducing in nature. That's why it will give you greenish brown precipitate. Just like sugar, any reducing substance, homogentic acid can also answer positive Benedict test, right beta? Alkaptonuria patient beta, chetan, no beta, no, doesn't present with much of mental retardation. Mental retardation is actually seen in case of beta phenylketonuria. Please remember, here we have severe mental retardation beta. Please remember this beta, severe mental retardation. And also in case of tyrosinemia type 2, mild mental retardation. Just try to understand here beta, A and C they can give you mild mental retardation. Phenylketonuria, very important, severe mental retardation, right beta? Important point to be noted beta. Yes, question number 20, short question, not much long, we can read it. 25-year-old lady, OPD, shortness of breath even on climbing one floor. One episode of chest pain. Lipid profile was remarkable with serum HDL almost close to nil. On examination, following was seen. Diagnosis. Diagnosis. Diagnosis, beta. Diagnosis. What is diagnosis, beta? What is the diagnosis? Diagnosis, bolo, beta. Nidhi, Umapathi, Gora, Afsal, Junaid. What is the diagnosis beta? Yes, yes, Gora, no beta, no beta. Please remember the correct answer. Yes, Onkar, 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 Ginni. Yes beta, yes, yes. Please remember the diagnosis of this is Tangiers disease beta. Tangiers disease, this is classical picture of orange yellow tonsils. This is classical picture of orange yellow tonsils. Orange yellow tonsils. Orange yellow tonsils. Please try to look for the other findings beta. Shortness of breath, one floor, unable to climb, chest pain, lipid profile remarkable with HDL almost close to nil. Please remember, Tangiers disease is also known as hypoalpha lipoproteinemia. Hypoalpha lipoproteinemia. Hypoalpha lipoproteinemia. Alpha lipoprotein is our HDL. HDL is a good cholesterol and this HDL is almost close to nil. So that's why LDL will be now taking the upper hand and there will be high chance of atherosclerosis. There is also predisposition towards MI, shortness of breath can be there, also chest pain, angina can be there in these patients. Tangiers disease, orange yellow tonsils. It is a fatal disorder beta, almost incompatible with. Yes, I hope the link is again established back. Yes beta, I hope this is, yeah. Middle aged male presented with the hepatosplenomegaly and the following finding depicted in the picture: subcutaneous deposition. Please remember this beta. What is this deposition? Look, yes beta, this is cholesterol. Yes, great. Cholesterol deposition, cholesterol tendon, extensor tendon of our hand on this side, extensor tendon of our hand deposition. Please remember, seen classically in primary familial hypercholesterolemia. Primary familial hypercholesterolemia. This is the type 2A beta. Type 2A of hyperlipoproteinemia. That is the most common type beta. This is the most common type of hyperlipoproteinemia, right beta? So these are basically the tendon xanthomas. These are basically the tendon xanthomas of our extensor tendon, right beta? Tendons and, yes, primary, yes. Melo rocking, yes beta, you are definitely rocking beta, yes. Primary familial hypercholesterolemia, yes, that is the answer beta. Yes, LDL receptor, great beta. Gaura, yes, great beta. LDL receptor deficiency. What is the deficiency here beta? LDL receptor deficiency, great beta, great. LDL receptor deficiency, yes. LDL receptor defect, LDL receptor defect, please remember beta. Primary familial hypercholesterolemia, great. Most fatal, yes, most fatal. Autosomal dominant. What are the other features beta? We have something known as xanthelasma. Please try to follow here beta. Sometimes we will be having LDL or cholesterol deposition at the near the inner canthus of our eye with xanthelasma, and over the cornea also there can be a layer, whitish ring of LDL can be deposited, known as corneal arcus. So three important findings: tendon xanthoma, corneal arcus, xanthelasma. Diagnosis is primary familial hypercholesterolemia, right beta ji? Important point to be noted. Yes, yes, great, great, great. Which diagnostic modality was used? Let us try to read the question. Look for positive findings: neonate, few days after birth, lethargic, refuses breastfeeding, vomits during breastfeeding, accept glucose water, diarrhea on the third day, clinical examination, develop pod belly due to hepatomegaly, urine RE reveals presence of galactose in urine. Galactose in urine. Galactose in urine. Case of galactosemia, just now we have discussed. Galactose is a reducing sugar, should be diagnosed by. Answer is yes. All of you are correct beta. All of you are correct. Answer is Benedict test beta. Benedict test. Great. क्या बात है? Benedict test beta. Answer is Benedict test, right beta? What about Schilling test, where we use the radioactive cobalt? All of you know that is done for vitamin B12. Rothera's test is actually done for ketone bodies, and oxidase peroxidase test is actually done for glucose. So right beta ji, important point, please remember this beta. Schilling test, where we use the radioactive cobalt 60 for B12, Rothera ketone body, oxidase peroxidase, glucose. Benedict test for all reducing sugar. Here it is a galactosemia, galactose in urine, right beta? Possible explanation, read the last line first. Possible explanation for these findings is a deficiency in function of which of the following coenzyme. That means we have to read the question, we have to see what is going on over here. Let us read it. Look for positive findings. Oh my god, they have already told you the diagnosis here. Normal screening for PKU. They are telling it is a case of PKU, phenylketonuria, already mentioned. Male, newborn, phenylalanine 35, 20 cutoff, more high. Positive test, signs of tyrosine deficiency also apparent. Enzymatic analysis using cultured fibroblast obtained after circumcision shows normal activity of phenylalanine hydroxylase. Oh my god, this is a bouncer question. ये क्या हो गया? ये तो योरकर से भी खतरनाक है. What is this? They are telling it is a phenylketonuria patient, but phenylalanine hydroxylase enzyme is normal over here. How this case is presenting? Please try to understand here, beta. I told you repeatedly that even in cases of some coenzyme deficiency, although enzyme might be normal, but coenzyme deficiency may lead to the disorder, beta ji. Important point to be noted. So please remember, what is the important coenzyme for phenylalanine hydroxylase? इसका coenzyme क्या है? All of you know the answer is tetrahydrobiopterin. This is tetrahydrobiopterin. Tetrahydrobiopterin. Please remember, beta, the answer to this question is option number B, beta. Please remember, this is a bouncer question. आ सकता है. This is a bouncer question, beta. Not pyridoxal phosphate, not B6, beta. Not B6, not B6, not B6, not B6, not B6. This is not B6, not pyridoxal phosphate, beta. Here what they have told, it is a case of PKU, phenylketonuria. Definitely diagnosis has been done, but not due to enzyme deficiency, but due to coenzyme deficiency. What is the coenzyme for phenylalanine hydroxylase? If you recall, beta, this is biopterin. This is biopterin. Important point, beta ji, isko yaad rakhna hai. Biopterin. Let us see the reaction. All of you will remember this now, that phenylalanine to tyrosine. Let us see this mechanism, how it happens. Phenylalanine is the essential amino acid converted to tyrosine. This is the non-essential amino acid, right? All of us know this. This reaction is happening in the liver, done by the enzyme. What is the name of this enzyme? Phenylalanine hydroxylase. Please remember, beta, this phenylalanine hydroxylase enzyme requires a coenzyme that is known as tetrahydrobiopterin. देखो यहाँ पर 4 हाइड्रोजन है बेटा. Here we have 4 hydrogen. Tetrahydrobiopterin, which donates to hydrogen and get converted to dihydrobiopterin here, right बेटा? ये 4 था, ये 2 में convert हो गया. 2 hydrogen got added with phenylalanine over here. So 2 hydrogen is getting added here and it is converted to tyrosine. Now please remember, if you do not have these 2 hydrogen coming from tetrahydrobiopterin, even though the enzyme is present, still phenylalanine can't be converted to tyrosine. So this is an important coenzyme, and the coenzyme is biopterin. If this is deficient, even though this is present, still the reaction can't be converted because there is a deficiency of the coenzyme. This sort of phenylketonuria cases, God level doctor, you have answered it correctly. This is a case of non-classical phenylketonuria. Great, beta. This is a case of non-classical phenylketonuria. I hope all of you have got this now, beta. Enzyme normal hai, enzyme hai, koi deficiency nahi hai, but the coenzyme which helps this enzyme is missing. So biopterin deficiency leading to non-classical phenylketonuria. Right, beta? Important point. Bouncer question, expected question may come. Please remember, beta. Phenylketonuria. PKU. Phenylketonuria, beta. Phenylketonuria. Great, beta ji. Phenylketonuria. Please remember. And this enzyme which actually converts this dihydrobiopterin to regenerate this tetrahydrobiopterin by dihydrobiopterin reductase. If this is deficient, also we can have phenylketonuria. Right, beta? Hope all of you have got this. Phenylketonuria, enzyme and coenzyme both are important. Right? What is the coenzyme here, beta ji? Coenzyme here is biopterin. इस ये नाम को भूलना नहीं है. This is biopterin. Right, beta? So here biopterin was there. This is the answer to this question, right, beta? Enzyme normal, coenzyme missing. Yes. Which of the following amino acid is most likely to be decreased in this patient? Let us read the question carefully, beta. Give the optimum respect to this question. Read it carefully. 65-year-old man, coronary artery disease, follow up, 6 feet tall, 84 kg, BMI almost normal, BP also normal, lung field also clear to auscultation, vesicular breath sounds can be seen, Cardiac examination show no point of maximal impulse within normal limit. Serum studies show glucose concentration also normal and homocysteine concentration quite high, more than 15. 5 to 15 is normal, 19.3 micromole. Serum lipid concentrations are within the reference range. Which of the following amino acid is likely to be most likely to be decreased in this patient? Answer to this question beta. What is this diagnosis? इसका diagnosis बोलो. This is a case of homocystinuria. Homocystinuria, right beta? Homocystinuria. Homocystinuria. Homocystinuria क्या क्या होता है? Let us quickly see the pathway बेटा. हम लोगों को क्या डिस्कस करना है? What we have to understand, following amino acid में से कौन सा likely to be decreased in this patient. Now let us see what is homocystinuria. All of us know most common cause of homocystinuria is the deficiency of enzyme cystathionine beta synthase, right? CBS, cystathionine beta synthase. This is the name beta, cystathionine beta synthase. This enzyme might be deficient, and if you have this enzyme not present, what will happen? Homocysteine will not enter into the pathway for production of cysteine. पहले cystathionine, then cysteine. So homocysteine will be increased in this patient if this is missing, right? Tries to correlate here this with this, right beta? No confusion here, right beta ji? Hope you are able to follow this. No confusion here, right beta? Right beta ji, hope you are able to follow this. No confusion. Cystathionine beta synthase is the most common. Please try to understand, apart from that, we had also studied that this particular cystathionine beta synthase enzyme is dependent on B6 or pyridoxal phosphate, and homocysteine that usually gets converted to methionine synthase back to methionine. This is dependent on B12, and this methyl tetrahydrofolate that donates the methyl group to homocysteine to get converted to methionine, this is actually in the form of B9. So B6, B9, B12 deficiency can also lead to homocystinuria, right beta? In all these cases, just try to understand, if homocysteine is, there is a deficiency of this either B12 or B9, what will happen beta? If B12 or B9 or this methionine synthase enzyme, just try to look here beta ji, just try to look here, if these are deficient, what will happen? Homocysteine now can't be converted back to methionine. Important point to be noted beta, homocysteine can't be converted back to methionine. So what will happen beta? In case of homocystinuria, that might be due to deficiency of B9 as well as B12 or deficiency of this methionine synthase enzyme. Just try to look at this black color cross sign that I am putting here beta. Please try to understand. If B9, B12 or methionine synthase, MS stands for methionine synthase. What is MS beta? MS stands for methionine synthase, which regenerates methionine by the help of B12. This enzyme is dependent on B12, right beta? So if the coenzyme vitamin or the enzyme or the B9 which was carrying the methyl group here, if they are missing, then methionine regeneration will actually be decreased. So what is the answer to this question beta? Please remember here, which of the following amino acid is most likely to be decreased in this patient? Arginine is not associated with this pathway, neither leucine nor lysine. Answer to be remembered as methionine. Answer to be remembered as methionine. So please try to understand here beta, methionine. Methionine, right beta? Please remember this beta, methionine. Important point to be noted, methionine beta. Methionine is the answer to be great, right? We are just seeing some important features of homocystinuria. One of the features, I'm not going into the detail beta, just try to understand that they will actually have a tall stature, and one of the most important finding, please remember beta ji, try to look for this lens dislocation In homocystinuria patient we have downward lens dislocation beta, whereas in case of Marfan syndrome we have superior temporal, that is upward dislocation of lens, whereas in case of homocystinuria we have downward dislocation of lens. So these are one of the eye changes, ectopia lentis, seen in both Marfan and homocystinuria, but in homocystinuria it is downward, Marfan upward, right beta. Let us move to the last MCQ of the day of our session, number 25. Most likely vitamin deficiency in this condition. Read the question carefully beta, read the question carefully. Last question, don't jump. 40-year-old, OPD, lethargy, weakness, SOB, climbing stairs, routine investigation, high homocysteine level. That means homocystinuria is present in this particular patient. Obviously just now we have seen homocystinuria will be present, and urine for methyl malonyl CoA was normal. Normal. Answer. Methyl malonyl CoA normal. Just now we have seen methyl malonyl CoA will be increased only in vitamin B12 deficiency, not in cases of B9 deficiency. As here it is normal. Yes, Greta, Zen, Pavan, Vinod, Rizwana, great, great beta, great. All of us can remember the answer as folic acid beta. In this question, most likely vitamin deficiency is folic acid. Just try to correlate with the last question beta. Just try to see here one more time. B12 and B9 deficiency both can lead to homocystinuria, right? But if there is B12 deficiency, we will having methyl malonylic aciduria or methyl malonyl CoA in urine, one of the marker. But in B9 deficiency, we do not have methyl malonyl CoA in urine, right beta? So please remember the answer to this particular question, last question of the day. We have methyl malonyl CoA normal, so can't be a case of cobalamin beta, can't be case of cobalamin or B12. This is folic acid beta, folic acid. Hope you all had understood the main concept and the points that I had shared along with the MCQs. Hope these are helpful for you beta. Thank you for joining the session, and thank you for giving me a patient hearing. Thank you for sitting for biochemistry discussion for almost 2.5 hours. I will just like to quickly conclude with this. May everyone pass beta. May each one of you pass. You have done your hard work. You have gone through the journey of your tough time. Last 4.5 months or 5 months of preparation for you has been really tough. So many sleepless nights. But always think about where you are going beta.